Hello friends, welcome back after the break. Friends, you're listening to the live teleconferencing session organized by the National Board of Examinations and Indira Gandhi National Open University. And the subject we are covering today is surgery and the topic on obstructive jaundice. We have experts from Maulana Azad Medical College and Sir Gangaram Hospital, New Delhi with us, and they're deliberating on the various issues of surgical jaundice today. Dear friends, I'd like also to remind you that we also be having a radio counseling session today between 5 to 6 p.m. on 105.6 FM Gyan Vani channel of the Indira Gandhi National Open University. The topic for today's discussion would be how to write a thesis and a protocol and various points about it. This is going to be a live phone-in program, the telephone numbers of which will be announced during the show. So do join in during that time also and clear all your doubts about your thesis writing and protocol writing, etc. Without any further ado, I'd like to now invite Professor Malik to give his talk on obstructive jaundice. So,
we have covered two important sessions by this time, and we have by this time reached the diagnosis and in a stage where we'll start the process of management of the patient. It has to be a very elaborate step-by-step approach, and one has to be very comprehensive and exhaustive in the workup, in the information gathering before embarking upon surgery, because as we all know that operating on a patient of obstructive jaundice is at times a mammoth undertaking and can result in quite a few complications if attention to detail is missing. Now, what all information we need to have before we embark upon the process of treatment of such patient? We have to be very clear whether we are dealing with an obstructive jaundice or we are dealing with a non-obstructive jaundice, an issue which should be sorted out on the basis of history and basic investigation. Are we dealing with a patient of intrahepatic cholestasis, which is predominantly a medical condition, or we are dealing with an extrahepatic bile duct obstruction? Extrahepatic bile duct obstruction with jaundice is an entity called surgical obstructive jaundice, and that is the topic of discussion for this evening. What is the site of obstruction? We have to be clear about the site of obstruction, whether it is the hilar obstruction, whether it is the mid-CVD obstruction, or whether it is the distal obstruction or a pancreatic malignancy. What is the cause of obstruction? We have to know whether it is malignant obstruction or the benign obstruction. Is it because of a previous surgical operation, or is it because of any other rare entity called choledochal cyst or maybe ascariasis? We have to know the extent of the disease and complication. Extent of disease and complication would become an important aspect of discussion when I come to my next slide. Then again, we have to know the status of liver function. Some patient may be having pre-existing liver disease, on the background of which they have acquired a new entity of disease like a gallstone disease with a bile duct obstruction or malignancy of the liver, cholangiocarcinomas. So on the background of a pre-existing chronic liver disease, if the patient has acquired some new biliary condition, or if there is a long-standing obstruction which has started affecting the liver, the way it was discussed in the first part of the presentation, that there could be leakages and this could result in the hepatic fibrosis and biliary cirrhosis. And the most important aspect, which has been said the last but is very important, is condition of the patient. We have to know what is the condition of the patient, what kind of comorbidities our patient is suffering, and these comorbidities related to respiratory tract, related to coronaries, related to diabetes should be thoroughly looked at. And also we should categorize our patient if he's got liver involvement on the basis of child's grading. So that will give us roughly an idea of the kind of risk that this patient suffers or this patient is likely to have if he is offered surgery, and performance status. Now, there is no point offering any mammoth surgical exercise to a patient who is bedridden and who is terminally sick. So, one should have a very decent idea about the performance status of the patient. After gathering all this information, it would be possible to and this is of course though the numbers listed here are maybe 6 or 7, but the information about these can be gathered in a day or two of workup. Now, when we plan therapy for surgical obstructive jaundice, we have to immediately categorize the conditions into two entities. Are we dealing with benign entities or are we dealing with the malignant entities? Benign entities are common ones. I have just picked up 6 conditions because otherwise the list is quite endless, but they would give us a bird's eye view of certain types of situation one is more commonly likely to encounter. Benign entities are choledocholitis, bile duct strictures, choledochal cysts, and in the malignant, CA gallbladder, CA pancreas, and bile duct cancer. When we are talking of benign condition, it is important that we should know what kind of complication the patient is having. That's what I meant when I was on my previous slide, that we must know what kind of complication this patient is having. Is he having any cholangitis? Is he having any acute cholecystitis? Or is he having any pancreatitis? So, it's important to know what kind of attendant complication our index patient has, or if it is the setting of a choledochal cyst, it's also important to know whether he's got any concurrent cancer in that cyst. When we talk of malignant obstructive jaundice, it is important not only to have an idea about the diagnosis, but also its local and regional and metastatic spread. So, all this information would be required to select the kind of therapy that we'd offer. Though it is the surgical obstructive jaundice is now an entity which I think soon will become something which will be less talked about, and there would be an entity which will be just an obstructive jaundice to be dealt with either by surgery or with endoscopic method. So, when we talk of surgical obstructive jaundice, it is not that surgery is always to be done, but it is an extrahepatic obstruction, and surgery is one of the alternatives by which you can manage it. There could be an endoscopic management available or laparoscopic management available for these entities too. Now, when we talk about palliation, I think there are very important things to understand. Whether it should be surgical or a non-surgical palliation, it should be importantly understood. And it is said that surgical bypass gives best palliation. That is, a surgically constructed bypass is the most durable bypass. It has it decompresses most effectively and is likely to be is unlikely or less likely to be complicated by complications of cholangitis and things like that. Having said that, there is a question mark, and you will understand why I put this question mark as I go along the list. Surgical palliation should only be done if a planned resection doesn't appear feasible on the table. So that means in the elective setting, there would be very rare time that you will go in with the idea of a surgical bypass, that I will bypass it because on the basis of investigation the patient's lesion is unresectable. Going in such a patient for a palliation is currently not recommended by the available studies. Palliate if patient is symptomatic. You don't palliate a disease if the patient is not symptomatic. If patient has to have symptoms, and we'll come to as to which symptoms are the ones which require palliation and which can be managed otherwise. Palliate if there is a reasonable life expectancy. We wouldn't like to palliate a patient whose life expectancy is judged to be less than 6 months. So, patient need to have a life expectancy of at least 6 months. Otherwise, palliating such a patient is an expensive exercise which yields very little dividends. As a matter of thumb rule, I would say that in advanced disease, I would like to still palliate a patient. If the patient has got a locally advanced disease, he may still be a candidate for palliation, or he would be an ideal candidate for palliation, but a metastatic disease generally would not be a candidate for a palliation as we understand by way of surgical or an endoscopic method. Yes, to improve the quality of life in these patients, we may give them other helps or symptomatic help. Now, we have to set what are the criteria for resection of malignant lesions right quite early in the scope of this presentation, and then only we can say that these are the things that I have to obtain information about in my investigative workup and then move forward. So, the aim is that we should be able to remove and resect the disease with clear margins. That means all around 3-dimensionally we must achieve clear margins. Adjacent lymph nodes, if they are involved, are not a contraindication. For example, if there are peridocal lymph nodes are present, that's not a contraindication. But if there is a regional spread to the mesenteric, to the retroperitoneal or celiac group of lymph nodes, then it's a contraindication for surgery, for any resective surgery. Metastatic disease contraindicate resection is very clear, and involvement of superior mesenteric artery, superior mesenteric vein, inferior vena cava, hepatic artery and portal vein in majority of the centers would be a contraindication for resection. So when we are looking at these patients, we have to have clear idea about the lymph nodal status, about the metastatic status, and about the involvement of the vessels, great vessels. In the setting of these involvements, we would not offer any resective surgery to this patient. So therefore, these patients would by and large come up for non-surgical methods of palliation. Now, when we have to prepare the patient of obstructive jaundice for surgery, and this could be a it will initially begin as an exercise of a resective surgery with a curative intent. It may end up as a resection for palliation, or it may simply end up as a bypass. But preparation has to be quite thorough and has to look at various aspects like coagulopathy, and as we have been told, 2, 7, 9 and 10 are the factors which are vitamin K dependent, and doing any surgery in the setting of coagulopathy is a disastrous can be followed with a disastrous consequences. So therefore, we have to ensure that we quickly reverse the coagulopathy. By and large, we will be able to reverse this coagulopathy with the help of fresh frozen plasma or vitamin K. And since an element of both the things may be there, some degree of liver dysfunction and some vitamin K dependent deficiency. So if you are wanting to prepare your patient for surgery, then it's better done with fresh frozen plasma and achieve the INR, that is international normalized ratio of 1 or close to 1, by giving about 4 units of fresh frozen plasma. Your patient could be ready for surgery on an urgent basis. Otherwise, for a leisurely approach, you have vitamin K. Hypoalbuminemia is part and parcel of liver involvement. Generally, in the setting of obstructive jaundice of short duration, of benign nature, hypoalbuminemia will not be very marked. But in malignant conditions, and it is a marker for the severity of the disease, not so much for the nutritional status. A patient of hypoalbuminemia should be taken up with lot of caution, because such a patient runs a higher risk of morbidities as well as mortality. Then again, hepatorenal shutdown is a possible complication in these patients, and while you are preparing these patients, you have to hydrate these patients very well. That is one aspect. Bowel preparation to take care of the endotoxins is another important thing, and during surgery, giving mannitol to these patients has been shown to be one way of ensuring that these patients have good urine output. And during the phase of surgery also, they should be looked after very well. It's also important that a low dose dopamine, which is considered to be renal protective, should be instituted in these patients who are at risk. And hepatorenal shutdown is a likely possibility or a greater possibility in patients with obstructive jaundice, in the malignant obstructive jaundice, and in patients who have a high level of bilirubinemia, and those who have been having it for a prolonged period of time. So these markers should be used, that is the duration for which the patient is having obstructive jaundice, number 1, number 2, malignant obstructive jaundice, presence of cholangitis, and the degree of jaundice. So all these things are suggestive of a higher mortality in these patients, or higher possibility of hepatorenal shutdown, and preventive action should be taken against it. Then again, these patients are anemic for various reasons, and one of the most important reasons is that their disease intake, or the disease their intake after they have been stricken with the disease is low, and they they are not in ideal metabolic stage either. So these patients are likely to be anemic, and their anemia should be corrected before surgery. And it's important to say here that hemoglobin should be in the range of about 10 or little less than 10, and one should not attempt to raise the hemoglobin to 12 or 14, considering that that will be the best for the patient. No, we have understood that hemoglobin that blood works better which has a hemoglobin of 10 or under 10, because the viscosity and other hemodynamic parameters work better at that stage. Second is that initially, because of dehydration, and since vomiting is part and parcel of any obstructive jaundice process, mostly some of these patients would be having poor intake also. So these patients may be giving you a false sense of normal hemoglobin level, but in fact they may be having anemia, and that should be checked only after you have corrected their dehydration. So this kind of preparation, a thorough preparation for these patients, is required before the patient is taken up for surgery. Now, if we are talking about palliation, and I said that palliate when there are symptoms, and which symptoms to palliate? If the patient has cholangitis, that is one symptom which requires palliation, and if the patient has severe intractable itching, and as I said the word intractable, that means you have used those interventions which Dr. Jan had mentioned in his presentation, the opiates and also maybe cholestyramine, and these things, if they have not worked, or maybe cyproheptadine. These are three important drugs which have been around for the treatment of, or for the amelioration of itching that these patients experience, and if these don't work, then you should think that okay, this candidate may be benefited, or it ideally will be benefited by some kind of a palliation. Now, what are the modalities of palliation? The medication is one which I have already mentioned to you, with cholestyramine, then cyproheptadine and opiates. Percutaneous drainage, that is percutaneous biliary drainage, can be a very useful way, but then here again there will be a catheter outside, and which will have the possibilities of slipping out, which can get blocked, and which can be cumbersome nursing problem. So percutaneous drainage as a modality of palliation is a poor option and should be applied in a patient if other options are not available. Endoscopic stenting, either with the help of a ERCP or with the antegrade and prograde method, that is, you endoscopically you enter the distal bile duct, and from percutaneous route you enter the proximal bile duct, core out the malignant core of the lesion, and then introduce a stent. That is the best way of stenting these patients. Laser and other energy sources can be used to deobliterate the lumen to place an endoscopic stent. So endoscopic stent is the best way, and these metallic stents which have high rate of I would say patency are the ideal ones. Surgical bypasses are available. There are segment 3 bypass, hepaticojejunostomy, choledochojejunostomy and cholecystojejunostomy, and surgical bypasses by and large will be done in the setting of a patient who has a jaundice, whom you have taken up for an operative resection, and you find that the disease is not resectable. Such a patient can come up for the type of bypass, biliointestinal bypass, indicated in his given condition. So this is by and large the spectrum of things that we should consider. By and large, most of the patient preoperatively, when the disease is judged to be unresectable, advanced disease with a life expectancy of 6 days or so, 6 months or so, should undergo percutaneous biliary drainage or endoscopic stenting, and endoscopic stenting is superior, and that would be ideal. Surgical bypass only in those situations where you have taken up the patient for surgery, but you find that the going inside is not possible, and you go in for bypass. Now this is one way of endostenting, and here we have entered the biliary tree in a percutaneous manner. We go into the bile duct, and that's the site of malignant obstruction. You core it out, and then you place a stent. So it's a percutaneously placed endostenting. Similarly, you can do the endoscopic endostenting also, when you come with the help of a ERCP scope, enter into the distal bile duct and core out the lumen of the bile duct and introduce your endoprosthesis. Now we'll look at some aspects of bile duct stones and what is the best way of dealing with bile duct stones, what are the various things which are available in the armamentarium. Now this is endoscopic retrograde pancreaticography, and after an endoscopic retrograde cholangiography, you introduce a papillotome and divide and do a papillotomy. By this way you enlarge the opening of the papilla. You can enter the enter the basket in this bile duct from the papilla, engage the stone and take out the stones, or you can visualize the stones and with the help of a baby scope, maybe you can visualize the scope and break it with the energy source like a holmium laser. So this way most of the stones are tackled. Some of the of course this kind of procedure has its own complications, as was mentioned by Dr. P.N. Agarwal. That could be a pancreatitis, could be a cholangitis, and could be injuries to the duodenum. So an experienced person should be doing it, and one should not go with an idea that these are innocuous procedures, minimally invasive procedures, and therefore they would not have any complications. Complications and devastating complications are known to attend upon these procedures, and therefore one should apply these procedures with a clear understanding that ideal patients are subjected to it. And what are those ideal patients? Where the stone load is small, where the size of the stones are smaller. If the stones are 2 centimeter or 3 centimeter, they may be difficult to take out from this. And again, the experience of the endoscopist or interventionist is going to be of tremendous importance to us, and an experienced person using various types of energy sources or mechanical lithotrip, whereas for an endoscopist, he should or he would like to stay within his limits and tackle only the smaller and favorable stones. So those stones which are managed today, I think it is by and large accepted across the board that those stones which can be managed with the available infrastructure in a hospital by endoscopic method in the trained in the setting which is well equipped with trained endoscopist, the stones should ideally be managed by this method. But it is not the only method. There could be at times, when this method is not available or the expert is not available, then we need to be having other options available to us. Now this is laparoscopic method of handling the stones. Here we are having as a prelude to laparoscopic cholecystectomy, we are introducing a basket through the cystic duct, and this cystic duct under the radiologic control provided by the C-arm fluoroscopy will engage the stone here and will be able to remove this stone this way. Or the second way is using a choledocoscope through the cystic duct, and this may be a little difficult thing to manipulate into a small sized cystic duct. This is under the fluoroscopic guidance provided by the C-arm. You can do a transcystic exploration, or this is the second way is by using this choledocoscope, visualizing the stone and engaging it in the cystic duct. But you would always require one of these two methods if you are doing a lap transcystic CBD exploration. It's a laparoscopic thing, and here both the procedures are being done simultaneously. You are doing a laparoscopic cholecystectomy as well as removal of these stones. And as far as transcystic CBD exploration is concerned, it is said that this can only take care of very small stones which are less than 1 centimeter in size. Another method available is lap CBD exploration. In the similar manner as we have been doing open cholecystectomy and CBD exploration, we open the bile duct here, and through this opening you can visualize the stone with the help of a choledocoscope, or people in our setting have been using these cystoscopes. Rigid instruments go, they say, more conveniently into this. You visualize the stone and engage them with the basket and then close the CBD over a T-tube. So it is just a laparoscopic way of doing the conventional CBD exploration with T-tube drainage. Not only this, we can also terminate this procedure with this laparoscopic totally laparoscopic choledochoduodenostomy, the same way as we were doing in the open era. And that's the way we do choledochoduodenostomy. And this is a procedure which is being done for those situations where we are either dealing with secondary stones. Secondary stones are the ones which have been detected following cholecystectomy and 2 years after cholecystectomy. That means that there is something wrong with the drainage of the bile duct, or we have multiple stones here in the bile duct and there is a large CBD. So in this setting, a choledochoduodenostomy is a very convenient and very effective procedure. It's done with the interrupted suture. CBD is opened in a vertical manner, and juxta CBD bile duodenum, the first part of the duodenum, is opened in a horizontal manner, and a diamond shaped anastomosis is constructed the way it is shown here. Now, choledochoduodenostomy is a bypass, and this would be done for maybe any obstruction which is present in the retroduodenal or infraduodenal obstruction. If there is an obstruction, if there is a stricture here, so the one can do a bypass by constructing an end to side choledochoduodenostomy, which is done on a Roux-en-Y pattern, and that's this may also be required to be done in a setting of triple bypass, where we now believe, as I'll come to in that section, that in the triple bypass generally we have been talking about cholecystoduodenostomy, but today we have understood that cholecystoduodenostomy doesn't work so effectively as choledochoduodenostomy. So this is one way of doing a choledochoduodenostomy. However, you may not need to disconnect the bile duct here. You may do a side to side anastomosis in a Roux-en-Y loop with the choledochoduodenostomy construction. This is a standard method of doing hepaticoduodenostomy for biliary tract injuries and stricture formation, and this anastomosis has to be about 2.5 centimeter here. You should open the left duct to the extent it is possible and construct a anastomosis between the hepatic duct here, which is extended onto the which is extended to the left duct, and it becomes by and large a opening on the anterior aspect of the hepatic duct and the left duct, and you have opened the side of the jejunum, and you are doing what is classically called as Roux-en-Y hepaticoduodenostomy, which is a standard method of doing repair, or which is the standard method of salvaging patients of biliary strictures. Sometimes when the confluence is involved and confluence is totally destroyed, one has to go in for what is called as isolated anastomosis of both the right and the left ducts separately into the Roux loop, and this is a demanding procedure, should be done by those people who are experienced into it, and would generally be better done with the help of stents inside. So this is a hepaticoduodenostomy, a standard hepaticoduodenostomy, which is good method of treatment for strictures like bismuth 1, 2 and 3, but when we are dealing with 4, then we have to go in for isolate for separate anastomosis of right and left duct into the jejunum. This way we'll be able to manage most of the biliary tract strictures following cholecystectomy or following any other operation. I shall now talk to you about CA gallbladder with surgical obstructive jaundice. And by and large, it is considered that CA gallbladder, when it presents with obstructive jaundice, the disease is far advanced and it is beyond the scope of any radical curative exercise. For a resectable disease, the gross there should be no gross extraductal disease. That means the disease should be within the biliary tract. There should be no vascular involvement of the portal vein or the inferior vena cava. There should be no gross lymphatic disease, and there should be no systemic spread. So these criteria should be met when you plan to do a radical cholecystectomy. So by and large, a radical cholecystectomy is an option when the patient presents, and the very few patients who present with obstructive jaundice. But a patient with CA gallbladder presenting with obstructive jaundice would generally have a large extraductal disease or vascular involvement at the porta hepatis, and therefore the disease may not lend itself to a curative resection. In an odd patient where it is possible, one should go in for a radical cholecystectomy, which will include an en bloc resection of the gallbladder with segment 4 and 5, bile duct, complete excision of the bile duct with periductal lymphatics, and removal of the gastrohepatic omentum and celiac nodes. If all this is possible to do, then it's a good chance for the patient, and the Japanese work has shown that this has some role to play, but only very few patients would be eligible for a radical cholecystectomy in the setting of CA gallbladder with obstructive jaundice. Now let's talk about bile duct cancer a little bit. Bile duct cancer, the various types have been described by by Blumgart and his colleagues, and various important aspect is that this is a proximal one, proximal which is involving the confluence, proximal which is predominantly involving the right duct, proximal which is predominantly involving the left duct, and proximal which is involving both the ducts. So this is what is classically called as Klatskin tumor also. The treatment for these conditions: for proximal bile duct cancer, the resectable disease should be that there should not be a gross extraductal disease, there should be no vascular involvement of the hepatic artery, there should be no gross lymphatic disease, and there should be no systemic spread. Encasement of hepatic artery and involvement of second order duct will preclude any curative resection. Now, I think this needs to be understood. Involvement of hepatic artery is very important in the diagnostic workup to look at the hepatic artery, and if it is involved, then one should abandon. It's the stem of the hepatic artery I'm talking about, and not the right and left branches. And again, then second order, that means the first is the right and left duct, and then there are two anterior and posterior sectoral duct. If there is involvement of the ducts beyond that, then it precludes any curative resection. And how do we know about it? As Dr. Agarwal very rightly said, that we need to know the ductal anatomy very thoroughly. For this, PTC done both into the right and left duct gives the ideal information, which is the Japanese way of doing it, or recently contrast CT with 3D reconstruction in multi-slice can also give the same information. But here you have to be very clear about the ductal anatomy, and any involvement beyond the second order duct would preclude any resection. In sum, therefore, proximal bile duct cancer may involve may be treated by liver resection with right and left hepatectomy, that is depending upon which side the tumor is going. If it is growing into the right duct, you may need to remove the right liver lobe, and if it's going into the left, then you have to go into the you have to remove the left duct. You have to make sure that you are getting negative margins. If you are getting positive margins, it's just a palliation which is not indicative. Complete extent of the bile duct and periductal lymphatics should be removed, and gastrohepatic omentum and celiac nodes should be completely removed. So this all is required in the setting of a proximal bile duct cancer. However, if the cancer is involved in a localized manner to the hilum and it can be removed without removing the liver, that approach is also possible in certain confined cancers. And for the mid CBD cancer, simple excision of the duct with periductal lymphatics and gastrohepatic omentum is all that is required. For the tumors at the lower end of the bile duct, for the pancreas and periampullary disease, what is required to be done is a Whipple's pancreaticoduodenectomy, which means out here, I think it has been shown as pylorus preserving variant of Whipple's pancreaticoduodenectomy. It should be called as pancreaticoduodenectomy because Whipple described pancreaticoduodenectomy, which was not a pylorus preserving, where you would be doing a partial gastrectomy. So here we have shown that for lower end CBD, for periampullary cancers, and for the CA head of the pancreas, whenever disease is resectable and resectable for cure, the treatment is a Whipple's procedure, whether you apply a pylorus preserving or non-pylorus preserving. Then again, we have choledochal cyst, and choledochal cyst is a rare entity, though in the adult practice. We see it maybe once or twice in a year, and it can present with obstructive jaundice, with cholangitis, and generally seen in the younger adults, but can be seen in the older individuals also. When we see a choledochal cyst in an older individual, there should always be a concern about an attendant cholangiocarcinoma occurring in the cystic duct, in the choledochal cyst, and investigation should be directed to pick up that tumor. There are 5 types, as we know. Type 1 is the most common, which is a fusiform dilatation. Then there is a outpouching, which is type 2. Choledococele is 3, and type 4A is when there is an intrahepatic plus fusiform dilatation. When there is a fusiform dilatation with choledococele, it's 4B, and 5 is Caroli's disease, which is multiple cysts in the liver. By and large, the commonest variety is type 1, and most for type 1 and type 2 and maybe type 4A, and for this, resection of the cysts and hepaticojejunostomy is the form of treatment. For choledococele, transduodenal manipulation, transduodenal excision of the choledococele is the treatment. For this Caroli's cyst, if it is localized to one segment, one needs to go in for a liver resection. However, extensive Caroli's disease may require liver resection and transplantation. This is one presentation to show what it means to remove choledochal cyst. You have to remove the cyst and the distal end just at the place where the bile duct is dipping into the pancreas is securely ligated, taking into consideration that these patients are likely to have some kind of abnormal pancreatic opening, and therefore one should not really be tempted to go quite deep, because abnormal pancreatic junctions are known in this patient, and obliterating that would set the stage for post-operative pancreatitis. The cystic cyst should be completely excised. Today, in today's context, the rarest of the rare patient will qualify for cholecystojejunostomy bypass. By and large, excision of the cyst and followed by hepaticojejunostomy reconstruction is the treatment of choice, which has been proven durable in the long term and has given lasting good results. So after this presentation, we know that this is an extensive surgical undertaking. Complications are known in all extensive surgical conditions, surgical operations, and these operations are known to be attended by complications in quite a significant number of patients because of 2 reasons. One is that delicate reconstructions are required in these patients, and whenever we do delicate operations, there are bound to be certain lacunae here and there. Second thing is that we are doing these operations in compromised patients, and therefore there are possibilities that nature may not be assisting the cause of surgery to that extent as it does in the benign condition. Leaks are quite common, and leaks from the biliary tract behave in a very benign manner. If there is no dismemberment, if these are contained leaks, if they are draining to the outside, these leaks will close over a period of time. So leaks are nothing to be worried about, but yes, leaks when they are not draining outside, and leaks, if there is today the patient has drained a liter of bile and tomorrow it suddenly stops, that means that somewhere our drain is not working, and it may set the stage for abscess formation and peritonitis. Hepatorenal shutdown, I mentioned, is a very important entity, and one should be always in guard for it. If it occurs, the treatment is only dialysis. Wait for expect that the patient will improve, but the prognosis becomes very poor. So the best way of addressing the problem of hepatorenal shutdown is to prevent it by the various approaches that I had mentioned in the first section of my presentation. Cholangitis is because of manipulation, because of loop reconstructions are more likely to be attended upon by cholangitis, and if you have done a choledochoduodenostomy without ensuring that the distal bile duct is patent, such patients can have cholangitis, and cholangitis would need to be treated very aggressively if you want to prevent the mortality in these patients. Post-operative pancreatitis, because of the manipulation of the ampulla of water, is a problem which can happen, and this is a problem which is even worse when it happens to the remnant of pancreas in Whipple's pancreaticoduodenectomy. So one should always be on guard against post-operative pancreatitis. If your patient is not doing well and all other things are okay, then you suspect that probably post-operative pancreatitis is one reason for the patients not doing well. Early in the course, you should always repeat the amylase studies to pick up pancreatitis and institute the conventional supportive treatment for pancreatitis, and be on the lookout for the further complications of post-operative pancreatitis. As I mentioned, that leaks, when they close off without completely resolving the problem, can give rise to intra-abdominal abscesses, and one should manage these abscesses as he would in any other situation. As well as peritonitis is concerned, I think it requires that one should go in, clean up the peritoneal cavity, and provide a make a situation which was a diffuse situation, convert this situation into a controlled fistula. I mean, if your patient has leak, there is no point going in and repairing the things that have happened. Everything is edematous out there. It may not be possible to repair it. So the best way to manage this situation is to provide for controlled drainage in this situation, make a controlled fistula, and these patients will improve over time. You can always go in a second time and mend the ill effects of your previous surgery. With this, I think we have come to the end of this presentation, and be very happy to answer any question that my presentation has generated. Thank you.
Thank you very much, Dr. Malik. We have students here in case you want to ask some questions. And dear friends, you were listening to us to the studios of the Indira Gandhi National Open University all over India. Dear friends, in case you have any queries, our phone numbers are 011 2953 2844 and 011 2953-2845. The toll-free number is 1800-11-2345. Dear friends, in case you have any questions on obstructive jaundice, please call us and clear your doubts. We have expert group of panel doctors here so that your doubts are cleared and you become better clinicians in future. We're waiting for the calls, 1 or 2 minutes.
I have one question for Dr. Malik. Like, there is always a confusion among the student that while doing radical cholecystectomy for carcinoma gallbladder, is it always mandatory to remove the CVD, or you can avoid removing the CVD for carcinoma gallbladder?
Well, as far as radical cholecystectomy in the setting of carcinoma gallbladder is concerned, I think in this what people at Sir Gangaram Hospital are following, the gastroenterology people that I know, because that's the group with which I interact these days. For those patients who have obstructive jaundice, and for those patients who have peridocal lymph nodes, they would always go in for the resection of the bile duct, and that means that in their hand, therefore the operation will become a cholecystectomy with a wedge with the removal of right up to the celiac axis, gastrohepatic omentum. So that's the kind of a radical cholecystectomy they would do for a patient of obstructive jaundice. However, if the patient